Hey everyone, welcome to this explainer. Today, we're unpacking something absolutely crucial, the clinical guidelines for stratifying and managing diabetic foot risk. We're going to be drawing on some really rigorous standards, including the latest updates from the International Working Group on the Diabetic Foot, plus Australian national guidelines. The goal here is to build a clear, actionable roadmap for preventing severe complications. Let's get right into it. Okay, so let's set the stage here with the actual stakes. 20 million. That is the estimated number of people worldwide affected by diabetic foot ulcers every single year. I mean, it's just a staggering figure, right? It represents a massive global burden. We're talking disability, mortality, and astronomical healthcare costs. And the harsh reality is, without appropriate timely care, these ulcers aren't just about localized pain. They are quite literally the leading cause of lower extremity amputations, serious infections, and major hospitalizations. So the prevention and proper management of these ulcers, it is genuinely a matter of life and limb. To get a handle on this, here is our roadmap for today. 1. The crisis. 2. Core screening components. 3. The risk tiers. 4. Screening frequencies. And 5. Offloading solutions. All right, Section 1. The crisis. Let's dive in. So how do these actually form? Well, it essentially boils down to a pretty dangerous equation. High repetitive mechanical tissue stress, stuff like plantar pressure and the shear forces that just accumulate during normal walking, combines with a loss of protective sensation. Now, usually pain is our friend, right? It's an alarm that tells us to take a rock out of our shoe or to change how we're stepping. But because of peripheral neuropathy, which affects around half of all people with diabetes, that protective alarm system is completely silenced. Moving right along to Section 2, core screening components. Now, what's really fascinating here is how strictly a quote-unquote risk factor is defined in these clinical guidelines. We're not just talking about general health risks, we are zeroing in on the direct culprits behind ulcer formation. So in this specific context, a risk factor means peripheral neuropathy, peripheral artery disease, structural foot deformities, or a past history of foot ulcers or lower extremity amputations. So how do clinicians find those specific risk factors? Well, they rely on the rule of 3 for comprehensive screenings. First up, the neuropathy assessment. This uses a 10-gram monofilament to carefully check sensitivity. Second, a vascular assessment, which checks for peripheral artery disease by actually palpating the peripheral pulses. And third, a deformity assessment, where things are graded on a comprehensive 6-point scale looking for issues like small muscle wasting, Charcot foot deformity, bony prominences, and limited joint mobility. Which brings us perfectly to Section 3, the risk tiers. Okay, this breakdown is absolutely essential for understanding the definitive clinical logic based on the Australian NHMRC guidelines. Basically, it's a tiered system. A patient is considered low risk if exactly 0 risk factors are found on screening. Simple enough. They hit intermediate risk if exactly 1 risk factor is present, say just a foot deformity. But importantly, they have no history of ulcers. And then they jump straight to high risk if 2 or 3 risk factors are present, or automatically if they have any history of previous foot ulcers or amputations. It's also super critical to point out that specific demographic populations have distinct clinical protocols. For example, Aboriginal and Torres Strait Islander people with diabetes are automatically considered to be at high risk for foot ulceration right out of the gate, at least until a comprehensive screening assessment officially confirms otherwise. And hey, while we're on the topic of that high-risk tier, let's look at this phrase, diabetic foot remission. You might be wondering, why not just say healed? Well, the data is pretty stark. There is a massive 40 to 50% re-ulceration rate within the very first 12 months. So guidelines strongly recommend using the term remission. It serves as a powerful reminder to both the clinician and the patient that ongoing vigilance is required, because that high-risk status, it's permanent. All right, Section 4, screening frequencies. Here, you'll notice a really dramatic shift in how often care is provided. Low-risk patients, they need a comprehensive foot screen at least once a year. But the very second a patient crosses into that intermediate or high-risk territory, the frequency jumps significantly. At that point, they have to be evaluated by an appropriately trained professional every 3 to 6 months. And finally, Section 5, offloading solutions.
When it comes to prevention, or for patients currently in foot remission, standard off-the-rack shoes just won't cut it. Appropriately trained professionals will actually prescribe custom medical-grade footwear. These shoes incorporate specialized features. We're talking higher toe boxes, specific closures, and custom insoles, all designed to relieve plantar pressure at those high-risk areas, protect the foot, and accommodate any existing deformations.
However, and please remember this because it's a huge pivot in the clinical pathway, if an active plantar foot ulcer actually forms, regular footwear, even that custom therapeutic footwear we just talked about, is absolutely no longer recommended for treatment. To promote healing, the guidelines dictate an immediate, no-hesitation escalation to dedicated offloading devices. Simply put, you cannot walk an ulcer away in standard shoes.
And that perfectly sets up this incredibly detailed clinical pathway flow diagram straight from the International Working Group on the Diabetic Foot. Now, don't worry about reading every single little box right now, but do notice how the treatment logic branches out. The clinician has to first determine the exact location of the ulcer. Is it non-plantar, plantar forefoot, or the heel? And then they rigorously check for the presence of infection or ischemia before they select the specific offloading device.
Let's break down one of those paths. If a patient has a neuropathic plantar forefoot or midfoot ulcer and there's no severe infection, the absolute first choice intervention, backed by some seriously strong evidence, is a non-removable knee-high offloading device. Think along the lines of total contact casts built from specialized surgical materials. Why non-removable, you ask? Because the biggest advantage is in forced adherence. It forcefully reduces that weight-bearing pressure and literally forces the foot to rest so it can actually heal. But look, beyond all the advanced clinical devices, the guidelines really stress that empowered patients and their caregivers are the absolute front line of defense here. They need to practice daily vigilance, specifically these two steps. Check footwear for foreign objects before putting them on, and check feet for any abnormal pressure or trauma the moment you take them off. Why is this so critical? Because, as we discussed earlier, a patient with severe neuropathy literally cannot feel a rogue pebble inside their shoe. And that tiny pebble, it can cause a full-blown ulcer in a single afternoon. So armed with everything we've covered today, the clinical logic of the risk pyramid, the critical nature of those 3 screening pillars, and the absolute necessity of offloading pressure, I want to leave you with one vital question to consider, whether it's for yourself or the loved ones in your life. When was your last comprehensive foot screening? Thank you so much for joining us for this explainer, and we will catch you next time.